All right, all. Thank you for being here on time. Good afternoon. I'm excited to be able to share perhaps one of the most important lectures that you'll need going forward as you communicate with folks with a new spinal cord injury. And that's prognostic factors after spinal cord injury. What we're going to do is talk through the pathophysiology and anatomy a little bit. So that we remember exactly what it is that we're dealing with when we talk about a spinal cord injury. I'm going to talk through the literature going back from the 70s moving forward, and realize that a lot of this literature that I'm presenting today has come about since I've done my residency. And so we've got a lot of new information, but I'm going to talk through aspects of the INSCI exam that are going to influence prognosis for recovery, and particularly prognosis for ambulation. I'm going to talk a little bit about things that predict motor recovery, and then briefly discuss imaging prognostication. So as we go through there. Just as a reminder, your spinal cord injury is about the size of your little finger in terms of the circumference. And passing through that cord from the brain to the body are a number of descending tracts, including the cortical spinal tracts, vestibulo and rubrispinal tracts. You also have ascending tracts coming from the periphery of the body and ascending the cord to send information up to the brain. And then at about 1 centimeter intervals, as you go down the cord, you have afferent information coming in through the dorsal columns and efferent information going out from the anterior horns. And in between those, you have obviously the interneurons, which can be inhibitory or facilitatory as you're talking through that. And so this is a very simplistic cartoon, I get it, of the cord. But then you can imagine what happens when you have a significant contusion injury, an ischemic injury, etc. And just as a reminder, what happens after that? So you develop ischemia because of vascular ischemia and infarct. The tissue in this area ultimately necrosis, and you have instead basically a 360-degree glial scar. Now that glial scar, I'm gonna go taking you back to, at least some of you remember Sleeping Beauty and the cartoon, and Prince Philip is rushing into the castle. And let's say that this is his path to get into the castle and up to the top of the castle. First, he had to crash through all of those brambles, those huge glial scars, if you will. And then he came and there was this chasm in between there. And so he's going to have to get across that somehow. Today, we can put cell preparations in there. So consider Schwann cells, stem cells, something like that, basically to make a crossing or a scaffold for him to get across there. But remember, if Prince Philip is really going to make it through there, he's got to fight off Derby dragons. Remember the dragons that he had to get through. And in fact, going across this chasm, you have all of these inhibitory proteins, the no-go proteins, myelin-associated glycoproteins, tumor necrosis factor alpha, nuclear factor kappa B. These are all hostile proteins to new axons, particularly motor neurons or sensory neurons, that are trying to traverse the cord through this chasm. Recognize that if somehow we found a way to fight off those inhibitory peptides, we would still have to provide growth factors, nerve growth factor, brain-derived neurotrophic growth factor, glial-derived neurotrophic factors, fibroblast growth factors, cycla A and P. All of these have to be there in specific concentrations at specific times in the neural cell's development. But let's say that somehow we were able to fight off the proteins, put scaffolding in there, get across this, and put the growth factors in place in a cocktail just right. We would still have a problem with directional guidance. And so that's the other thing, if I can find it here. Directional guidance. Maybe we're lost. and I'm stuck. So this would have been a great lecture except for that. So anyway, we are caught in this situation where I'm trying to move forward, and that's pretty much what happens with a spinal cord injury. You're simply not able to get through there. Let me see if I can do something else here that might help us a little bit.
Doctor, you can just click on the screen, click on the presentation, and then move the cursor left.
Yeah, there we go. So the bottom line is, without directional guidance, we could end up having significant misfirings because of miscommunications between different neural tracts that shouldn't be touching each other. And that expresses itself in neuropathic pain and in spasticity, among other things. So recognize all of this is happening through the size of your little finger. Basically, we have to figure out how can we repair, or will the cord repair itself? And so that being the case, I want to remind you of the anatomy. Within the cord and within those specific tracts, we have an arrangement such that sacral, lumbar, thoracic, and cervical fibers are running in that particular order, both for the sensory tract as well as for the motor tracts. And so in the late 80s, early 90s, Bob Waters, who's an orthopedic surgeon at Rancho Los Amigos in California at the time, had reports from patients, those who had reported having some sensation in the sacral dermatomes or myotomes basically seemed to have more recovery. And he went back and he looked at the anatomy in the cord and he goes, well, we ought to be taking this into account when we're doing our assessment. And so that's really why in 1992 we switched over from the Frankel classification, which had been in place since 1969, we still include many of the components of the Frankel classification, except that now we are much more anal. Yes, we really take into account the sacral sensation, sacral sparing, and motor sparing that goes into that. So the new standards, Asia has subsequently evolved into the INSCI, the International Standards for the Neurological Classification of Spinal Cord Injury, but we still use the Asia Impairment Scale, that is AIS scale, to denote whether an injury is complete, that is AIS-A, in which you have no motor or sensory sparing in the sacrum, and particularly no sacral sparing, period. As opposed to an incomplete injury, and that can be classified as either AIS-B, C, D, or E. So AIS-B is that you still have sacral sparing and you have sensory spared below the level of the injury, but no motor sparing. And that reflects an Asia Impairment Scale B. Asia Impairment Scale C also has sacral sparing. It has sensory sparing below the level of the injury, but now it has motor spared. Unfortunately, the majority of muscle groups below the level of the injury are less than anti-gravity strength. And so we're going to classify this as Asia Impairment Scale C. That is, the majority of muscle groups below the level of the injury have less than anti-gravity strength, as opposed to Asia Impairment Scale D, which denotes basically the majority of muscle groups below the level of the injury have more than 3 out of 5 strength. They are anti-gravity, they are functionally working. And you have sacral sparing. And then finally, Asia Impairment Scale E, you have normal sensation, pinprick and light touch. You have normal motor function, grade 5 throughout, and sacral sparing. So why do you even call it Asia Impairment Scale E, Dr. Gator? Because things are not normal. You still, because of the spinal cord injury, have lost some of the inhibition that keeps the reflexes in check. And so these folks, even though they may seem motor intact, sensory intact, are still at high risk for spasticity, hyperreflexia, particularly bladder and bowel spasticity and sphincter spasticity. And so they're not out of the woods just because they have this type of an injury. Keep in mind that incomplete injuries also incorporate these clinical syndromes of central cord that we've talked about, Brown-Séquard syndrome. I'm going to speak a little bit more about that specifically. Anterior cord syndrome, which affects just the anterior 2/3 of the cord, typically because of the great artery of Adamkowitz. being clamped off, conus medullaris, and then cauda equina. Okay, so these are the clinical tools that we use to help us determine the state at the time of injury, hopefully, as well as the prognosis for recovery. So our tools, yes, a wisp of cotton, if you will, and a safety pin. Really? I mean, in this day and age, this is still what we use. These are, yes, primary factors helping us to determine prognosis following a spinal cord injury. And so again, without beating these to death, each of these are scored from 0, 1, or 2. These are ordinal scales. Basically, a light touch is either absent, it is normal, the same as the face, or it is impaired, either hypersensitive or hyposensitive. Similarly, when you do a pinprick, the inability to distinguish between sharp and dull, even if they can just feel it, that's a 0. If they cannot distinguish between sharp and dull, that's a 0. 2 is normal sensation, same as when you touch the pin to the face. And 1 is impaired, either hyper or hyposensitive relative to that. And then we have our motor exam. All of you are familiar with this. Again, an ordinal scale. Basically 0 being no visible palpable contraction. A 1 is a flicker of muscle movement, but not enough to move the limb through its full range of motion with gravity eliminated. 2 is with gravity eliminated, they can move the limb through its full range of motion. 3 is they have full range of motion against gravity. 4 is full range of motion against gravity and some resistance, but not age and gender matched normal. And then 5 is age and gender matched normal strength through its full range of motion. So I'm not going to beat these to death, but this is literally the basis for a lot of the prognosis literature that we see with regard to spinal cord injury. And a lot of it comes down to, does a person have anti-gravity strength at the time of our initial evaluation, and or do they have trace? Even trace, typically what we're going to find will prognosticate into anti-gravity strength down the road. So the initial timing is going to be critical. We know that sacral sparing is a primary factor because of the topical arrangement with sacral, lumbar, thoracic, and then the cervical fibers being conveyed most medially. And so any sparing of light touch, pinprick, deep anal pressure, or voluntary anal contraction bodes well for recovery of function below the level of the injury. We want to perform the INSCI examination as soon as possible, and this is reported out by Shea and Kirschblum. Oh, this hasn't come out yet. This is in August. So, oh, this is August. This month, this article will come out. Shea and Kirschblum, basically talking about prognosis after spinal cord injury. So this is so hot off the press, it's still steaming, just so that you know. And they talk about trying to do the exam as soon as possible. Ideally, and we're going to talk about this within the first 3 days, practically speaking, sometimes we don't get to do a good ASIA or INSCI examination until the person arrives at rehab. Nonetheless, what are the factors that prevent us from getting a good INSCI examination acutely? If the patient is on a mechanical ventilator, it's sometimes difficult to communicate with them effectively. They may be chemically sedated and or paralyzed. They may have a concomitant brain injury, a psychiatric illness, a language barrier, or severe pain and or incomplete pain management. All of these can contribute to iffy examinations in the acute setting. And so nonetheless, the early literature particularly talked about trying to get the exam within 72 hours. Brown et al. Reported this in 1991. And part of that was between 24 and 72 hours is when we anticipated seeing the most amount of secondary swelling after spinal cord injury. And so it was felt that ideally you'd get an exam right around the 72-hour mark. Now, since that time, Bob Waters, who did a lot of the work at Rancho Los Amigos in the late 80s and early 90s, reported out historically, if we can get 1 week data, that would be helpful. But a lot of times nowadays, this corresponds to admission to the acute rehab facility. Now, those participating centers with the model systems programs, we are required to get INSCI examinations in the acute setting and at admission of inpatient rehabilitation as well as discharge, and then at 3, 6, and 12 months post-injury. So anyway, the initial exam is a prognosticator for the type of function we expect to see at 1 year. And what the early literature showed, Marino reported out in 2011, there doesn't seem to be a significant difference between 3 days or 7 days. So if we can get our first exam sometime in there, we can be relatively confident that that is going to help us appropriately prognosticate. The SIGEN database, the European spinal cord injury databases, they are still trying to collect and still recommending trying to get that initial examination within the first week of spinal cord injury. Now, a couple of things that are kind of caveats to the usual prognosis. Age, unfortunately, seems to play a role. And Wilson reported out in 2014, for individuals greater than 65 years of age, basically, FIM scores are going to be significantly lower at 1 year, as opposed to those individuals under 65 years of age. Generally speaking, their FIM scores are significantly higher. Now, interestingly, there's no age-related difference in motor recovery, whether you're 65 and under or 65 and older, nor does it seem to influence the Asia Impairment Scale conversion, the grade conversion. So for example, converting from A or complete spinal cord injury to AISD or C. Doesn't seem to be age-related, at least by this study. However, Olson, Christine, basically did a study reported out in 2016, again looking at age, and found that those over the age of 50 with Asia Impairment Scale A or B, so essentially motor complete injuries, those over the age of 50 were less likely to walk at 1 year post spinal cord injury. If they had preserved pinprick in the majority of dermatomes in the lower extremities, that seemed to predict ambulation only for those individuals under age 50. So again, we do have an age discriminator there. And then finally, if we look at the acute Asia Impairment Scale C, those with tetraplegia at time of discharge, basically those under the age of 50, about 90% of those are going to achieve community ambulation. What? Yes, if you have Asia Impairment Scale C tetraplegia, so essentially central cord syndrome, or in some cases Brown-Séquard. At the time of discharge, that bodes well. If you're over the age of 50, less than half as well. So less than 42% achieved community ambulation if they were Asia Impairment Scale C at the time of discharge. Now we have folks up on the unit right now that are in that in-between, Asia Impairment Scale C or Asia Impairment Scale D. And they're already wondering, am I going to walk? Am I going to have normal bowel and bladder function? And so start to think about application of this data as we move through this. So there was a lot of question in the 80s, 90s, and around the turn of the century. It seemed as if early decompression of a spinal cord injury would be a good thing. But we really had a hard time getting the studies done, partly because we couldn't get the folks in and stabilized and then consented soon enough to be able to get this done. But since that time, there have been a number of studies reported out, starting with Michael Feelings in 2012, reported out in the STASIS trial, that is the surgical treatment for acute spinal cord injury study, STASIS. And this was reported in 2012. in a cohort with acute cervical spinal cord injury. So early decompression, that is within the first 24 hours, those individuals were 2.8 times more likely to recover at least 2 ASIA impairment scale grades. Okay, so going from an ASIA A to an ASIA C, for example, at 6 months, versus those individuals who had decompression, surgical decompression, more than 24 hours after the spinal cord injury. So about 3 times more likely to recover significant function if you had early decompression. And this is based on literature back in 2012. In 2019, Terwingle reported out basically early decompression within the first 24 hours for complete cervical spinal cord injury. About a fifth of those would improve at least 2 ASIA impairment scale grades versus 10% for those decompressed after 24 hours. Again, less than 24-hour decompression seems to improve neurological recovery at the cervical level, not so much when we look at thoracic or lumbar spinal cord injury. And then there's some literature looking at ultra early, that is within the first 8 to 12 hours of decompression. And that data is really equivocal. We need to do more research. You would think, again, things would go better. But in some cases, it might be that they didn't have folks completely stabilized hemodynamically. And so it's not real clear that surgeries within the 8 to 12 hour range are more beneficial or not. But certainly within the first 24 hours, we can demonstrate that. Except, again, here's a caveat. If you've had a penetrating injury, that is a gunshot wound or stabbing, although most of the, well, all the literature that I'm showing on this slide has to do with gunshot wounds and not stab injuries. But a penetrating injury is going to be a little bit different beast. So you're more likely to have a complete spinal cord injury because of the high energy component of a bullet wound on the neural tissue, especially in the cervical and thoracic region. Remember, thoracic spinal cord injury is going to require high energy, basically breaking through rib as well as chest wall musculature. And so you're going to see a much higher degree of damage to the cord in this region. The thoracic cord, remember, is narrower. The canal itself is narrower, and it's a watershed zone. So you don't have as good a vascular supply. And so you're going to be less likely to recover following a gunshot wound, but even a blunt injury to the thoracic cord is going to be less likely to recover than cervical or lumbar injuries. So do we leave the bullet? Should it stay or should it go? Well, we have to decide. And again, the literature shows that in the cervical, and I should have said thoracic, I'm sorry, thoracic spine motor scores, those are significantly unchanged. The lumbar spine, there is a significant increase in lower extremity motor scores, so that you have 13-point improvement after removing a bullet, as opposed to 3.3 for leaving it in. So it appears that there is significant benefit, and part of this is because you've got a larger canal to work with. You've got a more extensive vascular supply to the lumbar cord, and the cauda equina is less likely to be damaged. A bullet can kind of slip through. It may hit off particular peripheral nerve roots as they're coming out, but it's not going to see the damage that you would see to the cord itself. And so this is based on data back in the 90s, but as well some very, very recent data reported out in 2019 by Carencia Zeta. I practiced that, and I'm still struggling with it a little bit. So what is the natural recovery, assuming that we get decompression and fusion so that the spine is stable? Che and Kirschblum will report this month that you're going to see most rapid recovery in the first 3 months. The majority of recovery is going to be within 6 to 9 months, and usually we see a plateau of the neurological recovery somewhere between 12 and 18 months after spinal cord injury. However, Kirschblum did report some neurological recovery even 2 and as many as 5 years after spinal cord injury. So while the chances are much, much less, there's still the possibility. And so I try never to take away that hope from somebody who needs the hope. And we'll talk through that a little bit more. Now, the initial ASIA impairment scale grade is going to be associated with motor recovery in the following way. ASIA impairment scale C generally recovers more so than ASIA impairment scale B. And both of those recover more than ASIA impairment scale D. And all 3 of those recover more than ASIA impairment scale A. Now, the issue with ASIA impairment scale D isn't that they don't recover, it's that we have a ceiling that we report out to. So once you get a 5 out of 5 strength, I mean, you can't do much more than that. And so some of that is due to a ceiling effect. We also note that the lumbar spinal cord injury motor recovery is about 35% compared to, again, thoracic, only about 10%, and high thoracic, even less than that. So what about conversion? What is the conversion rate from ASIA impairment scale A to some incomplete scenario? And again, Che and Kirschblum are going to report 20 to 30% of folks will convert from ASIA impairment scale A to incomplete. Now, the caveat here is, did you get a good examination from the get-go? So if your ASIA impairment scale A truly wasn't A, if the person actually experienced some sensation but didn't report it, if you were doing your examination and you thought that you had a reflex contraction around your finger rather than true voluntary contraction, maybe that wasn't an ASIA A from the get-go. So we have to be very, very careful and, again, very anal in the early stages as we're trying to determine prognosis for recovery. Generally speaking, you're going to see lumbar converting to a greater extent than cervical, to a greater extent than thoracic spinal cord injury. And of those who convert, especially at the tetraplegia level, about 50% will convert to ASIA impairment scale B. Remember, that's sensory spared below the level of the injury, but no significant improved motor function. And then about 50% will convert to motor incomplete, that is ASIA impairment scale C or D. A complete thoracic spinal cord injury is less likely to convert. And again, when you look at the numbers, the higher you go, the less likely you're going to see a conversion rate. So T2 to T5 complete will convert to ASIA impairment scale B only about 10% of the time. In the mid-thoracic region, a little bit better, T6 to T9 complete will convert to incomplete almost 16% of the time. And then lower down where you have a little bit larger canal, a little bit better vascular supply, you have the T10 to T12 complete, converting about 30% of the time. Complete lumbar spinal cord injury, again, will convert about 35%. So you have 1 out of 3 chance from the get-go, if you have a lumbar spinal cord injury, converting from a complete injury to an incomplete injury. And part of that is felt that some of the lumbar component is due to nerve root injuries, improved healing compared to just spinal cord. So what does motor recovery look like? So again, we get our motor exam and then we use that to some extent to help us determine prognosis for recovery. So most individuals with complete tetraplegia will recover at least 1 or more, but at least 1 level of motor function. And that means that for functional greater than anti-gravity strength, you need to have at least a grade 2 strength in order to become anti-gravity. So it's unlikely for muscles with 0/5 strength at 1 month to convert to anti-gravity strength at 1 year out. It almost never happens. So with regard to complete tetraplegia, that regain 1 level of motor function, 2/3 of those folks who are at a C6 level will ultimately end up with C7 tetraplegia. Approximately 16% will gain 2 levels of motor function. So if you have a C5 injury complete, it's likely that you will develop some anti-gravity strength in the elbow extensors. Likely, well, about 15%. And then to gain 3 levels of motor function, only 3% of individuals are able to gain functional strength beyond, when you talk about below the level of the injury, beyond 2. So a relatively small percentage will gain 3 levels of motor function. For persons with complete tetraplegia at between 1 and 4 weeks, 90% of muscles with manual muscle test of 1 or 2 will become anti-gravity manual muscle testing strength at 1 year. So again, I'm checking for folks who have a C6 injury, even a flicker of elbow extension bodes well for recovery to anti-gravity strength in the elbow extensors 1 year out. So that's why I'm watching so closely as we look through these. What about that was complete tetraplegia, what about complete paraplegia? And so again, as we look at motor recovery, most with complete paraplegia at 1 month will remain with complete paraplegia. That is Asia Impairment Scale A at 1 year. So 73% with Asia Impairment Scale A paraplegia won't have a neurological level that is different at 1 year than it was at 1 week. For those with injuries above T9, 0% regained any lower extremity motor function at 1 year. And again, part of this has to do with the watershed zone, the amount of injury, the energy influencing neural tissue in a watershed zone of the cord bodes very, very poorly for recovery. Below T9, you've got almost 40% with some lower extremity motor strength at 1 year. And those with injuries below T12, about 1 out of 5 ambulate with conventional orthotics and crutches. That's typically loft stand crutches and at least KAFOs, knee, ankle, foot orthosis, and or hip, knee, ankle, foot orthosis. But 1 out of 5 of those will ambulate. Now, that said, to ambulate with loft strand crutches and HKAFOs requires 6 to 8 times as much energy. And so folks who are doing this are doing it primarily for the hope of motor recovery and exercise, but not for community mobility, because they can hop in their chair and get across campus pretty quickly, expending only 9% more energy than you or I would take to walk. So a recent meta-analysis, again by Carancia Zeta, boy, I keep trying it, showed that complete thoracic spinal cord injury had the lowest rate of conversion, again 10%, and complete lumbar spinal cord injury had the highest rates of neurological recovery. So you're going to keep hearing this again and again. Motor recovery for somebody with paraplegia is going to be much better if it's lower paraplegia than if it's upper paraplegia. So what about sensory incomplete but motor complete? That is Asia Impairment Scale B paraplegia. And I guess I shouldn't say just paraplegia. This is also tetraplegia. The conversion represents about 10%, I'm sorry, about 10% of all spinal cord injuries will have Asia Impairment Scale B. The conversions over the first year, those who go from B to A, that is regress, somewhere between 10 and 20%. Now, is it truly a regression, or again, did we mischaracterize on our initial evaluation and reported out an incomplete spinal cord injury that was truly complete? I don't know for sure, and the literature is hard to tell. So just recognize when you see a regression, it might be that there wasn't a change. It might have been just reported incorrectly initially. Again, very, very anal on our early spinal cord injury exams. Asia Impairment Scale B, basically at 1 year, 20% are completely unchanged. So 20 to 35%, I guess, are unchanged. So you can see that these first two categories represent a significant portion of our Asia B population. Those who convert to Asia Impairment Scale C, that is, in the majority of muscle groups below the level of the injury, you have less than anti-gravity strength, somewhere between 25 and 35% of the time. You'll see that kind of a conversion. Less likely, you'll see conversion from Asia Impairment Scale B to a D, where you have more than anti-gravity strength in the majority of muscle groups below the level of the injury. Again, somewhere between 20 and 30% will make that conversion. So this is important, and again, why I really harp on getting these exams correct early on. If light touch, pinprick, and deep anal pressure are all present, there is a significant likelihood of motor recovery. If pinprick is spared below the level of injury at 72 hours after the spinal cord injury, there's an improved likelihood of community ambulation. Now, this was by Crozier. She put this out in the 1990s, 1991. And at that point, we hadn't converted to the INSCI or Asia exams. So her data is based on Frankel classifications and didn't look at sacral sparing. Nonetheless, if in the majority of muscle group, or not muscle groups, in the majority of dermatomes below the level of the injury, you had pinprick spared, then you would have an improved likelihood of community ambulation. And then Christine Olson reported out in 2005, sacral pinprick at 72 hours after spinal cord injury trended, but didn't predict ambulation at 1 year. However, if more than 50% of the lower extremities pinprick dermatomes were intact 72 hours, that was predictive of ambulation. So some little nuances there. And I really would encourage you to go at the end of this and look through a little bit. You're going to find some more details in these papers than I'm providing right now. What about motor incomplete, Asia Impairment Scale C and D spinal cord injury? Of those admitted to inpatient rehabilitation facilities with Asia Impairment Scale C, 44% remained Asia Impairment Scale C at 1 year. Over 50%, 52% converted to Asia Impairment Scale D at 1 year. If voluntary anal contraction was the only motor function spared initially, 0% of those converted from Asia Impairment Scale C to D. If the initial Asia Impairment Scale C included voluntary anal contraction, deep anal pressure, and light touch or pinprick, about 2/3 of those converted to Asia Impairment Scale D. However, if the person had Asia Impairment Scale C, voluntary anal contraction was present, deep anal pressure present, light touch was present, and pinprick was present at S4 and S5, almost 90% of those will convert to Asia Impairment Scale D. So again, the sacral component, we need to be very, very anal about reporting out pinprick and light touch and deep anal pressure and voluntary anal contraction. I need this information, you need this information, so that we can tell persons with confidence, what their prognosis looks like coming through there. So what about ambulation? This is, your typical, your gait, as you all know, going through the double support, single support, double support, single support, from right to left, reciprocal gait. Remember that reciprocal gait requires pelvic control and more than anti-gravity strength in bilateral hip flexors with at least one leg that has more than anti-gravity knee extensor strength. And this was reported way back in 1973 by Hussey and his group. So what about prognosis for ambulation? Ambulatory recovery is going to depend on the initial level and completeness of spinal cord injury, the lower extremity motor function present initially, the person's age, as we talked earlier, at time of injury, and then what additional impairments are there and how severe are they? Spasticity, balance, proprioception, and trunk control all play a role with regard to ambulation. And before I continue, let me go back to Hussey's 1973 article. He reported out basically 4 levels of ambulation: non-ambulatory, community ambulatory, which is characterized by ambulation with more than 150 feet, of more than 150 feet, not using more than 150, that's a lot of feet. Household ambulation, relative independence to get around within the household, and then those who ambulate for exercise, but not for community mobility. So the Rick Hansen Spinal Cord Injury Registry is similar to our Model Systems Registry, but it's to our colleagues in the Great White North, up in Canada. And so they use their registry and have put together a couple of predictor equations, the first of which was put forward by Van Medemdorp in 2011. And he used components including age, less than age 65, L3 motor strength between 0 and 5, S1 motor score between 0 and 5, L3 light touch score 0 to 2, and S1 light touch score 0 to 2. Used this to determine if folks were going to become ambulatory or not. And he would put these scores together. Hicks came by a few years later and used just 3 parameters, 3 of the same parameters that he used, but didn't include the light touch score or the S1 motor score. So Ms. Hicks looked at age, again, less than 65, L3 motor score between 0 and 5, and S1 light touch score. And they found that Asia Impairment Scale A and Asia Impairment Scale D, they could predict pretty accurately, more so than for Asia Impairment Scale B and C. And so incomplete tetraplegia, about 46%. So these, again, are primarily our folks with central cord syndrome and or Brown-Séquard injuries. Under the age of 50, 97% will become independent ambulators. And over the age of 50, about 40% will become independent ambulators, all right? Those with Brown-Séquard syndrome, 75% will become independent ambulators at the time of discharge. What? And 100%, in another study, 100% would become independent ambulators at the time of discharge. Now, the caveat here is this data goes back to the 70s. And I don't know if you know, but back in the day, the usual length of stay for a spinal cord injury in acute rehabilitation was 6 to 12 months, okay? So the time of discharge is a little different now than it was then. And so you can't take these numbers and just put them across and say, oh, you're going to be discharging at the end of the week, so there's a 100% likelihood you're going to be walking. No, 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 no. But you can still use the time frame that they talked about. So, for example, 79 days was reported out by Roth's group in 1991. Basically, almost 3 months after the time of injury as they're reporting out these scores. So nonetheless, incomplete paraplegia, 76% will become ambulators, and those with complete paraplegia, only about 5% will become significant ambulators as we go through there. So I'm trying to get all this in. This is pretty hard to squeeze in 1 hour, but I think that we're doing okay. Let me tell you a little bit about imaging and imaging for prognosis. So the neurosurgeons are going to be using this probably to a greater extent than we do. But there are predictive patterns looking at MRI signal characteristics such that if you have significant hemorrhage, typically this is going to be associated with a neurologically complete spinal cord injury. The size and length of that hemorrhage is going to indicate how severe the spinal cord injury is. The greater the size, the greater the length, the poorer the prognosis. And then the other thing is you can also determine approximately what the neurological level of injury is going to be by looking at the MRI and the upper boundary for the hemorrhage anatomic location. that corresponds in most cases to the neurological level of injury. So the neurosurgeons can say with some confidence, this is the level of injury without even having done a physical examination. On the other hand, the physiatrists, I expect you to do the clinical examination and then go back and use that as confirmatory evidence for the MRI. Edema has also been looked at. Generally speaking, if you got edema, then you're more likely to see neurologically incomplete spinal cord injury. However, the more edema you have, the poorer the prognosis. And if you have edema at multiple levels, that also heralds a poorer prognosis for recovery. So if you have no significant abnormalities on the MRI, squaiwara, spinal cord injury without radiological evidence, it's likely that you have an incomplete spinal cord injury, and it's probably less severe with a better prognosis for recovery. Now, the basic score for MRI was put forward by Talbot and crew in 2015. And so this is actually very, very practical. And again, I'm sure our neurosurgeons are using this. But this allows to predict the neurological recovery for both cervical as well as thoracolumbar spinal cord injuries. And this is a 5-point ordinal scale based on these descriptive factors. So basically looking at T2 weighted images, what they're looking for is this kind of a T2 hyperintensity. If you see this type of a signal, this is a basic score 1. And basically that means that this is confined to the central gray matter, a fairly good prognosis for recovery. If you have this type of basic 2, where you have intramedullary T2 hyperintensity extending into the white matter, so now that you're breaking outside of just the gray zone. This about 90% achieved Asia Impairment Scale C or D upon discharge. None of these actually became Asia Impairment Scale A. However, if they had a basic 3 score on their MRI, that is intramedullary T2 hyperintensity involves the entire extent of the cord. 2/3 of those are going to be discharged with Asia Impairment Scale A or B. And so this is bad. The only thing worse is this, and this is a basic 4. Now you've got spinal cord injury plus discrete T2 hypointense foci consistent with macro hemorrhage. 100% of those are going to be discharged with Asia Impairment Scale A. So I've given you an awful lot of information. What are you going to do with it? Your patients are going to want to know, doc, what are my chances for recovery? Am I going to walk again? And so this is not an easy discussion, and it's usually not a one-time discussion. It's usually a discussion over several days and or weeks. So we want to consider the person's autonomy, the beneficence rule, providing the best care, the obligation to do no harm, so now non-maleficence, and then justice, so our social obligation to being fair. And this means providing the same care for the DCR, so the residents of Dade County, as well, who don't have the top flight insurance, as well as those folks who come in able to pay for everything. We want to try to provide both the same level of care and the same way that we provide information about their recovery or lack thereof. So Kirschblum put together a nice article in 2016 and made the following points. The discussion should be led by an experienced clinician who knows spinal cord injury, not necessarily a physician, but at least somebody who knows about recovery and the things going on. We should use a trained health interpreter if there's a language barrier, so that you can clearly explain and the person can speak back to you and express that they understood what you were telling them. Sit at eye level and close to the patient. Speak simply, slowly, deliberately, clearly, and honestly. As you do that, use your eye contact and body language to convey warmth and sympathy, encouragement and reassurance. You can provide specific information as I've just put forward in this slide set. But I think more importantly, you want to let folks know that, while this is what the data shows, we are always hoping for a better recovery, and there are instances with folks who have your level of injury that have recovered. And so we will continue to work with you as much as possible to do this. Discuss the treatment options, avoid negativity to the extent possible, and then provide information about support services. What does that entail? Now, support services, these are, besides the physicians and the therapists, the psychologists are going to be very, very important. Peer counseling needs to be available. Family and friends are going to be contributing to support. And then spiritual and pastoral care also play into this. Recognize that a spinal cord injury is a matter of grieving for lost function. And folks will go through the grieving process of denial, anger, bargaining, depression, and acceptance. They might not go through this in order, and they might bounce back and forth and be angry one day, depressed the next, bargaining one day, accepting the next, and then being angry again. So this is a process. It is not an absolute stepwise process. And so we need to be aware that folks are going to have good days and bad days in terms of their psychological willingness to participate in therapy. And you need to be aware of that, checking their facial expressions, the way that they speak, their body language to the extent that they can use it to determine where they're sitting in the grief process and what things need to be brought forward to them. So I've covered an awful lot of material in about 50 minutes. I have some time for questions. And so if you have questions, go ahead and unmute yourself and bring them to me. Again, I can make these available to you as PDFs, and so you'll have all of these references as well, and who wouldn't want all of them, right? It's great reading, I can tell you. There's a lot of amazing information here collected over the past 50 years. So. Dr. McKenty.
Dr. Gator, yeah, I was just about to ask, more so for my own volition, if you can send us these out in a PDF today, I would love to start reading it again for myself, because it's all still relevant for us.
I think it's especially relevant to you on this rotation, yes. So I hear you. Other thoughts, questions, concerns? Yeah, Armando, how would you have liked to start with spinal cord injury and me? Sorry, first day. Yes, of course. It's difficult because this is perhaps, and different people will say different things, but this is perhaps the most complex of all of rehabilitation. And we talk about trauma in circumstances where you also have oncology and a couple of different tumors involved, as Dr. Mzambwe had 1 or 2 weeks ago, contributing to this. This gets very complicated, but you have all of those, usually 20 different comorbidities associated with spinal cord injury, and then at the same time you're expected to try to figure out prognosis for recovery. So don't worry, Nathan, I will help you through this week. We'll make it through.
Thank you, I need the help.
But it's, it's not something that comes overnight. This takes a lot of time, and we're here to assist you with it. So thank you all for mostly staying awake. I'm glad. This is a difficult lecture to give without having body feedback and not being able to see your facial expressions as I'm trying to work through this. But anyway, yes, I'll get the PDF to you today. Thanks all. Have a great day.